Ladies and gentlemen, the books is in. The books are in. Yep. They in. They're here. ETM Hotel, Rennie Shawn, welcome in peace. My name is Shawn. I'd like to thank everybody for tuning in to Science with Shawn. I think we're on episode 17. I hope everybody is having a nice afternoon. Before we crank up, man, like the show, share the show, tell a friend, tell a friend. We are in the building, we are live, and let's get to it. Today, we are going to go over a few things. We will be dealing with COVID conspiracies. I have a nice little, I got something nice for everybody that's tuned in today. I don't want to put it out there just yet. You know what I'm saying? I want to see who all in the building, and then we'll get to it. And if it's something that people appreciate, respect, and like, then, you know, maybe it'll be more of it. But I think this is a helpful tool to, you know, make Science with Shawn a little bit different than all the other shows that go on in the world of YouTube land, and you know. So yeah, man, like the show, share the show. Let's get some people in the building, and let's get to it. Y'all already know. I'm sharing it as we speak, so I just want to make sure that we get this out. I hope everybody had a nice little day at work. If you work, if you off, then I hope you enjoyed your day off. I got brother Sutek in the building with me. Just hopped on. I don't know if he prepared to speak, but you got something for the people, bro, before we get it going?
Yeah, man. Put it down. Share a lot for y'all need. Make sure y'all like and share the show. Appreciate y'all for coming through, man. When y'all get them little $600, y'all need to come see us. We got merch.
Facts, and the merch link is in the description. So yeah, he said when y'all get y'all 600, come see us. That's facts. That's facts. Um, Let me see. Let's see who we got in the chat right now, man. While we trying to get everybody up. Okay, Jerome, peace to you. Peace, Nunu. Robert Rand, peace. Zane was good. He said he was just watching the previous show. My bad for interrupting the previous show. My brother Rastaman in the building. You know what I'm saying? I see you in the building, bro. Before we get going, man, hold on real quick. Let me see. Yeah, I'm prepared. Let's see if we can get a few more people in here and we get it cracking. So right now what we're waiting on is we're waiting on AstraZeneca's data. We are waiting on AstraZeneca's data. As far as ivermectin, there's trials that probably need to be done on ivermectin before we can rule on anything regarding ivermectin. As far as the vitamin D thing, they are, you know, they did a trial on with vitamin D regarding people with, you know, with severe COVID-19, because they're saying many of the people who have severe reactions and things of that nature are having that vitamin D deficiency issue, and that was causing the problems. But they did some research in that on some people in Brazil, and that information is not turning up to be too proud. What up, LB? I see the troll is in the building. The number one troll, my bad. Peace, Dark Light. Appreciate that, brother. Appreciate that. DC in the building was good. Was happening. You know what I'm saying? Come on, man. You know, like the show, share the show. We finna have some fun today. You know what I mean? We're gonna have some fun. Let me get this link out somewhere else. I gotta put it in the pseudo groups. You know what I'm saying? Then let's see if we can get it going. Now, I guess when other people come in, you know, we can kind of deal with it from that perspective. And let me make sure. Yep. Okay. I got it out to the right people. First thing first. While we brother T'Challa in the building, while we waiting just a second to get the show started, I do want to thank everybody who have been tuning in to Science with Shawn. Because of y'all, we've been getting some pretty good feedback, and we also been getting some other type of feedback. You know what I'm saying? I know we're gonna have some peace get brother Gary. We're gonna have some people click on and click off and things of that nature. But I really would appreciate people to tune in. So let me mute this and let's take a look at some of the comments from yesterday's show. All right, here we go. It says, if you want to know how viruses spread, you need to know a little sociology. Really? That was enough to shut this video off. I guess he's mad at Vince Rancinello, who was a expert in the field of virology. So I guess, you know what I'm saying, I don't know who this guy is or his affiliation, but if he clicked off, unfortunately, that's bad. Can point me to your credentials and background, please? Thank you. So we have Gospel Outside is requesting my credentials and background. Well, I can provide you with a background of me, Gospel Outside. I don't know if you're watching this particular video or not, but if you just go down in the videos and things of that nature, you'll get a great idea about who I am and my background. And but I responded. So let's see how I responded. I simply said autodidact, who knows how to use proper research methodology and scrutinize sources, which allows me the ability to discern. I just kept it simple. All right. Orfnako U says good stuff. She's either a liar or a deep fake. Looking at the registered nurse website for Tennessee, there is no link. There is no K Mitchell under registered nurses, and you can see them through late November. Someone found someone by that name in Georgia, but their database also doesn't show any RN by that name or anything close to it. Facts. So people are hunting and looking. All right. So appreciate that. You know what I'm saying? Then another comment is, do you know it doesn't matter? The vaccine is dangerous and has been approved by the FDA. Why would the FDA approve a dangerous vaccine? It has been approved for emergency use, but not approved for nor accepted by the FDA. It is approved for emergency use. It is an EAU. All vaccines right now are can apply for an EAU. Applying for an EAU would give them the ability to be able to use it. We're in the middle of a pandemic. Now, they will be able to file for full use in a few more months. Where I get it from, I don't know if you're aware of that or not, but in a few months, because of the success and the efficacy rate of the vaccine and the more data that's actually coming out, in a few more months, Pfizer BioNTech is going to apply. Okay. Now, I listened to Moderna vaccine board meeting on Dr. Inky's site and heard it straight from their lips. Now, I don't know what you heard straight from their lips outside the fact that the vaccine is in an EAU status, but I would never be on a Dr. Inky. Inky's not a doctor. Okay. Since that's not true, we have evidence that we can analyze and deal with. Bring it up, Inky. He's not qualified, nor does he have the credentials to deal with this on a scientific level. All right. So I just responded to that. You know, we all know that it's in the EAU status. That's nothing different. You know what I'm saying? Me basically saying that is not true is regarding her first part of her statement, saying that the vaccine is dangerous. All right. I see we got Ogumbalaye in the building. Rasta Sticks Music is in the building. Brother Chavis is in the building. I see we got some more people in here, man. So that was pretty much the comments from that particular video. You know, every now and then we get some comments and we appreciate the comments, but you know, I start to go back to look because some people may ask questions and need further clarity on things. So we're trying to do a better job with following up with that stuff and deal with it. All right. Now, before we get going, I do have one question, and I'm gonna put this in the chat in case y'all want to use it, but it's also in the description. So for everyone watching the video right now, or who may watch or catch the replay, the link that I just put in the chat at this minute mark will be in the description. It's a true and false. All right, so everybody should see this on my screen, and we're going to deal with a little fact checking COVID-19 myths. And let's see how y'all do. Now I'm looking at the chat from my phone. So, you know, I'm going to go with the consensus. Ha ha. But I'm gonna go with the no, let me say that. Let me quit playing. I'm gonna go with the overall majority on each question that we're gonna ask. I told y'all we're gonna have some fun with this one before we get into the business. All right. So with the new coronavirus comes questions, as well as the potential for misinformation. Get up-to-date facts on the COVID-19 illness from Nebraska medicine experts. This is cool, right? Cool. Note that research is ongoing. Things change quickly, so check credible COVID-19 information sources for up-to-date information. That's peace. Now, question number one. Y'all ready? Put a one in the chat if y'all ready. Can't let y'all see question number two. Y'all tripping. Put a one in the chat if y'all ready, man. You know what I'm saying? All right. Peace, don't be misled. Okay, okay. We see the cock and scrub tech. Talking about bring it. All right. So question number one. One infected person infects about 2.5 other people. True or false? Put a T in there if it's true. Put an F in there if it's false. We're dealing with myths. Okay. I got one true. Two true. Three true. Four true. Five true. Six true. Excuse me. I'm gonna try to give other people opportunity to actually respond, and then we will go ahead and we'll see. Look like truths is dominating it. Said can infect. Okay. Rostic says true. Teddy peace. Teddy says true. CK can't say nothing. She driving. All right, it looked like the majority so far, people who do comment is saying true. People who just listening in, you know what I'm saying? I understand. So, all right, we're gonna go on to question two. Question two. Patients with COVID-19 can take anti-inflammatory medicine like ibuprofen, aspirin, and naproxen. True or false? Patients with COVID-19 can take anti-inflammatory medicine like ibuprofen, aspirin, or naproxen? True or false? Two truths, three truths, four truths. Come on now, y'all. We learning here. We dealing with vaccine. We fact checking COVID-19 myths. One false, two falses. 1, 2, 3, 4, 5, 6 truths and 2 falses. We got 27 people in the building, 28 people in the building. Like the show, share the show. Come on, family. We building right now. We learning. Look like the number drop a little bit. We got 3 falses, 6 truths. I'm gonna give y'all about another 15 seconds. You just put a T or F. Brother Chill in the building. We fact checking COVID-19 myths over here, Brother Chill. Appreciate the share. We learning over here. We educating. We doing it for the people. Scientific literacy and COVID-19 awareness. She's still on the clock and she say F for now. So you got 6 to 4. 6 to 4, and I'm gonna give you another 10 seconds for anyone else that wants to salute Brother Lamar Pope. Peace, bro. Show just now getting started. We dealing with true or false fact checking COVID-19 myths. Quiz number 1. We're having an interactive learning experience on the Mossy Warrior Clan based on all the information we done probably dealt with already. So it really ain't no curveballs, but it's just some awareness things that our people need to know. We got 6 truths, 4 falses. Anyone else with a false or true? I'm gonna count down from 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. The question is, patients with COVID-19 can take anti-inflammatory medicine like ibuprofen, aspirin, or naproxen. True or false? I'm going to give you an extended 10 seconds because there is a delay for you to answer the question. Since you asked again, DC. I know a lot of y'all are working. Yes, you can. 7 truths, 4 falses. Next question. One infected with coronavirus, it can take 2 to 14 days to show symptoms. True or false? Man, we better have a whole bunch of answers for this one. And y'all might have been confused on the medication, but this one, come on now. Come on, my people. There we go. We got a bunch of them truths in there. Sound like 2 chains. There we go. There we go. So we already know we got a majority right there. Everybody spitting fire on that one. All right. Question number 4. Hand sanitizer doesn't kill coronavirus because it's antibacterial, not antiviral. True or false? True or false? We got an F-bomb. One F-bomb. Rostick says false. Everybody saying false. False, false, false. We got 10 falses already. We got 25,000 viewers. We got 10,000 falses, 11,000 falses. Majority row. One true. 10 falses, one true. We need 5 more for 10 falses, 2 trues. Nope, my bad. 11 falses, 1 true. $11 falses, 1 true. 12 and 1. What up, Dave B? What's good, brother? We are taking a quiz, Dave. Presently, we are taking a COVID-19 myth quiz. We're dealing with 10 questions, 10 true or false questions regarding COVID-19 myths. Right now, we on question number 4. Question number 4 says, okay, we got 3 trues, 12 falses. The question is, hand sanitizer, does it kill coronavirus because it's antibacterial, not antiviral? Read again. Hand sanitizer does not kill coronavirus because it's antibacterial, not antiviral. I think Nunu cheating like a mug. Everybody saying the majority is false. Dave said true. All right, next question. Jerome says false. I'm telling y'all, she cheating. Healthy people should practice social distance. True or false? Come on. Come on. It should be 15 like in there, like right now. Healthy people should practice social distancing. True or false? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. At majority. At majority. All right, next one. During a shelter-in-place order, my kids can be with other kids in small groups. During a shelter-in-place order, my kids can be with other kids in small groups. True or false? DC says false. Ogunbola, yep, false. 2 falses, 1 true. 3 falses, 1 true. 3 falses. Oh boy, y'all all over the place. 3, 3, 5, 3, 6, 3, 7, 3, 7, 4, 7, 5, 8, 5. 9, 5. DC says stay in your house means stay your ass in the house. It's 9, 5. It's anybody's right now. 15, get it in. 10, 5. 10, 5. We got 28. We got 28 watching the 10 to 5. We need 5 more votes. I know a couple. I know CK driving, and I know Keish working. I don't know who the other people that tuned in, but come on, y'all. We need a couple of more. It's 10 to 5. And I understand too if y'all don't know how to chat anything. Yeah, so CK, during a shelter in place order, my kids can be with other kids in small groups. True or false? It's a sheltered in place. This woman that said she didn't stop to get tacos. Taco Tuesday was yesterday. Come on now. We need a couple of more answers. This thing thick. False is up 10. True got 5. All right, I'm going to count down from 10. 9. 10 to 6. She said true with social distance is 10 to 6. We're going to go with the majority since we don't have all participants answering questions. All right, next one. Anyone with COVID-19 symptoms, regardless of their overall health, should seek testing. True or false? Come on now. Peace, Black Star. You elaborated on that one. All right, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Need 13. 14. That's majority. All right. DC said I got tested. You got that wrong, DC? All right, next one. A loss of smell or taste is a symptom of COVID-19. True or false? A loss of smell or taste is a symptom of COVID-19. True or false? One more. Just one more is over. I'm gonna read it again. A loss of smell or okay, there it goes. A wrap. A loss of smell or taste is a symptom of COVID-19. All right. Last question. What up, Voss? If you can hold your breath for 10 seconds, you don't have COVID-19. True or false? mm. 1, 2, 3, 4, 5, 6, 7, 8. I'm gonna take that G as false. 1 true, 8 falses, 9 falses, 9 falses, 1 true. Yes, you can. If you can hold your breath for 10 seconds, you don't have COVID-19. True or false? Two trues, 13 falses. Still need a couple of more, okay? It's a wrap. Said false. Let's see how we did. Let's see how we did. Submit. Don't. Y'all ain't gonna give us no whole thing. All right. So here we go. Let's deal with it. Let's deal with it. Question number 1. Patients with COVID-19 can take inflammatory medicine like ibuprofen, aspirin, or naproxen. Answer provided true. Correct answer is true. There is not enough evidence at this time to say non-steroidal anti-inflammatory medications make COVID-19 symptoms worse. You can continue taking anti-inflammatory medications or acetylene. All right. Let's move on. Okay. I ain't gonna read all that. Once infected with the coronavirus, it can take 2 to 14 days. We said true. Correct answer true. After exposure to the virus, symptoms are shown soon as 2 days, as long as 14 days later. All right. I'm gonna read all of that. Now, hand sanitizer doesn't kill coronavirus because it's antibacterial, not antiviral. Answer provided was false. Correct answer is false. Hand sanitizer with at least 60% alcohol content per CDC does kill the coronavirus. The alcohol disrupts RNA molecules in the virus, preventing it from making copies of itself. You can make your own hand sanitizer at home. All right. Healthy people should practice social distancing. Answer provided true. Correct answer true. Healthy people everywhere should practice social distancing to help flatten the curve. Ways to practice social distancing include staying at home, don't travel, avoid groups. When you leave home or go to the grocery store, remain your distance, wear a mask. All right. During a sheltered in place order. During a sheltered in place order, my kids can be with other kids in small groups. Answer provided false. Correct answer is false. Follow the guidelines of local or state authorities. If your area has a stay-at-home or shelter-in-place order in effect, you should only leave home for reasons necessary to your health, safety, or welfare. Anyone with COVID-19 symptoms, regardless of their overall health, should seek testing. Answer provided true. Correct answer false. We got one wrong. We have never faced a pandemic like this before. And we have never faced testing shortages like this before. The COVID-19 test requires a number of chemical reagents, which are currently a very short supply in the United States. Now, at Nebraska Medicine, we are focused on testing those who really need it. All right. There's 3 purposes right there in front of us. We got one wrong, y'all. The majority got one wrong. Here we go again. A loss of smell or taste is a symptom of COVID-19. Answer provided true. Correct answer true. A loss of smell or taste may be a symptom of COVID-19. However, research is still ongoing and the predominant symptom remain fever, cough, and shortness of breath. All right. If you can hold your breath for 10 seconds, you don't have COVID. Answer provided false. Correct answer false. Most young patients with coronavirus will be able to hold their breath for much longer than 10 seconds. And elderly people. I ain't gonna read the rest of that. All right, now, if anybody want to retake it, you can go from there. If you like the quiz, if you like this quiz, you know what I'm saying? Whether you just listening into it and didn't have an answer, or you just here being nosy or whatnot, if you like that quiz, uh, put a 1 in the chat. If you're not really a fan of it, put a 2 in the chat. Three ones. That's all we getting. 4 ones. DC said 0.5. It was all right. Yeah, CK, I'm with you. Rostic Music said he got 7 out of 10. He said he need to brush up. It's all right, bro. That's what we're here for, man, to learn and brush up, bro. I'm not a fan of quizzes at all, but I feel it. Appreciate that. Appreciate that. I felt like today would be a really good day to pop a quiz on y'all. CK driving again, so I got one more quiz, but this one is just one answer. One question. Because the other stuff we haven't really talked about on here. So I'm going to go ahead and give it to you right now, and I want y'all answers. All right? Following an unprecedented worldwide effort, a vaccine for COVID-19 was developed in under a year, an astonishing medical achievement. The COVID-19 vaccines are a new type of vaccine called what? I'm going to read the question again. And then I'm going to give you the choices. Following an unprecedented worldwide effort, a vaccine for COVID-19 was developed in under a year, an astonishing medical achievement. The COVID-19 vaccines are a new type of vaccine called what? mRNA vaccines, live intuitive vaccines, inactivated vaccines, or toxoid vaccines? Come on now. I know everybody been building with me on Science with Shawn. Got to know this answer. Got to know this answer. All right, let me see how many people answered. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. All right, we need 12, 13. We need another answer. I ain't counting your answer twice, but I see why you're trying to correct yourself. Can we get somebody else to answer? Our bonus quiz for the day. One more time. Following an unprecedented worldwide effort, a vaccine for COVID-19 was developed in under a year, an astonishing medical achievement. The COVID-19 vaccines are a new type of vaccine called what? Oh, majority. That's correct. It is called an mRNA vaccine. The COVID-19 vaccines are a new type of vaccine that use mRNA to protect against the infectious disease, according to the CDC. To trigger an immune response, many vaccines put a weakened or inactivated germ in our bodies, not mRNA vaccines. Instead, they teach our cells how to make a protein, or even just a piece of protein that triggers an immune response inside our bodies. That immune response, which produces antibodies, is what protects us from getting infected if the real virus enters our body. Brother Mathis, you late, man. You late. Zane, for real, CRISPR. All right, so that was the bonus. That was the bonus right there, man. That was the bonus right there. So good job, everybody, on that. Let's move on and let's get into the bill today. Like I said, we dealing with conspiracies and all that, so it's only right that we deal with it from this perspective. I'm gonna press play. If you want to get your pen or piece of paper out to deal with what you're about to deal with, it's about to get interesting. This is about 32 minutes. I may stop it in between time, meantime. Let's see who we're dealing with today.
From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
I'm Jennifer Abbasi for JAMA Medical News. Today we're talking about a big problem in clinical medicine, health misinformation. My guest is Dr. Brian Southwell. Dr. Southwell is a communication science expert at the independent nonprofit research institute RTI International and an editor of the 2018 book Misinformation and Mass Audience. He's also a scholar with the Duke University School of Medicine and its Social Science Research Institute, where he's spearheading training for clinicians on how to deal with patients who come in with health misinformation. Dr. Southwell, thanks for joining me.
Great. It's really a pleasure to be here, Jen.
So, health misinformation has probably always existed. Before our call, I spoke with a primary care physician, and she said that patients still come in with magazine articles and books with misleading information. And of course, people get incorrect health advice from their friends and family. But how has health misinformation evolved with the internet and now in the era of social media?
Yeah, that's a really important consideration because in a lot of ways, misinformation has been with us for a very long time. Many of us have a sense of snake oil salesmen, for example, and that was rooted in a real example, historically. And so false and deceptive advertising in the medical arena has been around for a long time, as has been problematic information that you might get from a relative or other things you might hear about interpersonally. In the current moment, though, we're faced with this situation in which there's a dizzying array of information that's available to you very quickly. Now, you pick up your mobile phone, you hop on the internet, and you can find a lot in a hurry. And it's also the case that when you are faced with that information, you see something that you're perhaps excited about or interested by, you can share it so much more quickly than has ever been the case before. And so we worry about not only people's exposure to information, but also the diffusion of that information and misinformation in all sorts of ways. And so what I like about how you framed that initially, though, is there's a lot that we can learn from the past in terms of how people have engaged with misinformation historically that's going to be helpful. But we also need to think about some of the challenges of the moment.
How have we seen misinformation change since social media emerged?
Right. So one of the interesting aspects of social media is we might think about it in terms of a sort of flattening of the landscape in which it's difficult to tell and to trace the lineage or authorship of information in some ways. You might have legitimate information alongside information that might be much more problematic. And so that's something that we might worry about, is the sense in which there's sort of an equalized platform, and that may well give people the impression that all information is equivalent in terms of how useful it is or credible it is. Also, I think it's important as we think about misinformation to realize that it's not just one thing. It's not monolithic, that there's a wide range of it. It's long been the case that people have been able to encounter problematic information that's erroneous or inaccurate in different ways. But now it's also the case that you've got some people and organizations actively seeding the internet with misinformation. And so misinformation itself might cover the whole range of noise that we might think about, but some of the misinformation people are encountering has really problematic or nefarious authorship. It's also the case that misinformation varies in terms of how problematic it is. You might find something on some dark corner of the internet that really doesn't have much consequence for you in terms of your personal health. You also, though, might find and read or hear about misinformation that could kill you. And that's something that we also need to worry and think about.
So it sounds like you're referring to the difference between misinformation and what some people call disinformation.
And it's a really important distinction, I think, from an ethical standpoint, because you might worry ethically in terms of those that are actively seeding disinformation, those that are actively trying to fool or to be problematic in terms of what they're disseminating. But from the standpoint of patients, from the standpoint of those that we're trying to serve, all of the noise we might worry about. And so it may not necessarily matter as much in terms of the authorship if you are actually trying to help walk alongside people and to help them make sense of what's out there, because we know that their processing systems that people carry around with them tend to not necessarily differentiate based on who originally crafted a message unless they're aware of that source. And so that's something we might think about.
What type of health misinformation tends to be common on social media?
So I think it's important to realize that people use social media not just in search of the truth per se, but also to connect with one another and to bond with one another. And so if we think about information and potentially misinformation in terms of its currency, it's not going to surprise you that some of what travels on social media is that which is sensational or that which seems to be directly linked to everyday life. And so relevance really matters here quite a bit. We know that misinformation, which seems to be related to one's own personal well-being or the well-being of their loved ones, not only gains attention, but it's also something more likely to be shared conceivably. Similarly, we might think about more abstract scientific information, perhaps as being viewed as being more distant from people's everyday life and perhaps less likely to be shared. And so there's a little bit of an imbalance there. Right. And so if you think about an almost inherent advantage that many folks that are putting together misinformation might have, it's easier to craft something that's sensational or relevant if you have the ability to just put together whatever you'd like without necessarily worrying about it being true. Whereas folks that are operating from the standpoint of science and medicine often are thinking about the rules of peer-reviewed journals. They're thinking about the careful caveats that often accompany information. They're thinking about the abstract information that is necessary sometimes in writing up ideas for scientific journals. And so there is a little bit of a format imbalance almost that you might think about in terms of misinformation as it tends to get shared and spread in typical peer-reviewed scientific information.
It's a real challenge.
Mm-hmm.
Why are we vulnerable to believing health misinformation, especially during COVID-19? And what do these beliefs say about us?
Yeah, it's such an excellent question, Jen. And I really appreciate you thinking about our vulnerability in terms of something that we all share. Because as human beings, we are operating with human brains that have developed over time, but that tend to take in information in particular ways that we don't necessarily always pay close attention to. So there's a longstanding debate in psychology that's sort of neatly summarized by some of the contentions that were raised by a former philosopher by the name of Spinoza and another by the name of Descartes. And the sort of nutshell argument has to do with what happens when people encounter false information. Descartes essentially thought that people could know it when they saw it, kind of screen out false information. Spinoza had a subtly different argument and suggested that actually what happens is that we take in all information and then we make sense of it a little bit later. And that slight hesitancy, that sequence between taking in information and accepting it and then later tagging it as being false or true makes all the difference, because that's enough time to potentially share something on social media. That's perhaps enough time to forget to bother to critically engage or to not necessarily have the capacity to critically engage information further. And so you carry that with you. And so on some level, we're all vulnerable to sensational or other types of misinformation when we encounter it, at least for a moment. And so the question is, what can we do to encourage people to take that extra moment to critically evaluate what they're seeing? And generally speaking, to get people in a better spot in terms of critical engagement with their information environment. And so I think that's really important. Now, what people's acceptance of misinformation also says about them, I think, which is the other part of your question, is that we are human beings that have particular needs, and those are almost universal in a lot of ways. You think about the need that we have to be social and to connect with other people, the need that we have for hope for the future, the need that we have for basic safety and security and health and well-being. And what's interesting when you look at patterns of misinformation acceptance is that people are finding information that offers those things. And sometimes it turns out to be false or inaccurate. But nonetheless, if a piece of misinformation is framed in a way that offers you hope for the future, well, it makes sense that that would be something that you'd attend to. If misinformation is framed in a way that got one of your colleagues excited or a friend or family member and they shared it with you, again, it's sometimes important to connect with people, and that sometimes overrides our other critical judgment. So in a lot of ways, you might view people's acceptance of misinformation as partly a symptom of people trying to make sense of this crazy, chaotic world. Even in the case of conspiracy theories, I think there is at root there a hope that people have that somehow there is some explanation for the situation that otherwise is really viewed as problematic to them, that somehow there is some rationality to what otherwise seems like an open, uncertain future. And so I think that there's some attraction sometimes in misinformation that is succinctly and neatly offered to offer that kind of hope that people are looking for, that kind of explanation about the world. And I think that's a fair way to characterize some of the misinformation that tends to spread.
Can you contextualize that for COVID-19? So does this potentially explain why some people would rather believe that the pandemic is a hoax or is something that doesn't need to be taken that seriously?
I think what's been fascinating is, we've been thinking about misinformation for a while, but so much of this has come to a head here during this pandemic that we're all struggling through. And I do think that you're exactly right, that there is something about the types of misinformation that people are holding on to that offers them, some encouragement. It's easier perhaps to believe that we aren't actually facing this global pandemic. So, and at least initially, I think that may explain part of the reason why people would, turn to those types of conspiracy theories, for example. Similarly, people are looking for a relatively convenient and easy way to address what is a really threatening problem. There has been some more dramatic misinformation that's been spread, but some of it's been relatively mundane. There are recommendations to drink a lot of water as a way to protect yourself or pass the virus, which we know don't seem to hold up. And I think that's been important to note, not just because that information is false or inaccurate, but because it somehow was offering some kind of explanation to somebody or was offering them a concrete action that they might take. And I think that turns out to be really important for people in what's frankly a scary time. Even people that are holding on to information that seems to deny the larger contours of the pandemic, probably underneath that, on some level, are feeling some degree of uncertainty or fear that they're trying to somehow ameliorate with the false information.
Okay, I want to talk about the clinician training you developed at Duke. So what inspired it and what evidence did you draw from and what are the basic principles?
So over at Duke University, I've had the great and good fortune to connect with a number of colleagues in the medical school who have been worried and concerned about misinformation for a number of years. A few years ago, I had opportunities, for example, to connect with Rob Califf when he was at Duke, the former FDA commissioner. And Rob has worried about medical misinformation and its potential effects on society for a long time. And so in that context, the question then becomes, well, what can we do about all of this? And one of the, I think, important answers that came out of many of those conversations is that actually clinicians themselves may well be part of the solution. And frankly, occasionally are part of the problem as well. And I'll explain what I mean by that. So something that we've found is that many clinicians have had the frustrating experience of their patients wanting to point to misinformation that they found online or that they've heard from somebody else. And in fact, actually, earlier this year, along with my colleague Jamie Wood, we did a survey with the North Carolina Medical Board of a couple thousand licensed medical professionals in North Carolina. And we found that actually more than 90% of them reported the situation of having encountered a patient that was believing misinformation, who had brought it into the examination room essentially to talk about it. And at the same time, we also found that only a small minority of those same respondents, less than 20%, had ever really been trained in any kind of way to deal with that situation. Mm. So you've got this pressing concern, and yet most people don't know exactly what to do about that. So the question was, could we come up with some ideas, some guidelines? And what we did is developed a workshop that really emphasizes a few different themes. The first is something that we've just been talking about, which is this perhaps non-obvious realization that actually we need to think about patient psychology a little bit differently. Maybe not focus right away on just how wrong somebody is in terms of bringing in a piece of misinformation, but first to realize that actually we're all in this boat together, that we all are vulnerable to misinformation. And so I think that leads towards a stance of greater empathy and compassion than sometimes is the case. It's also the case that those kind of conversations, frankly, are just awkward and difficult. And so part of the guidance that we offer has to do with how to manage those challenging or difficult conversations. And so we offer advice, for example, in a very time-limited clinical encounter, to not waste your time, not spend time discrediting sources, and to not necessarily go into a heavily technical explanation as to why something is wrong. And importantly, not to shame the patient for being wrong. But instead, viewing it as an opportunity seems to be really crucial. So not only can that be done in terms of your own body language, you think about the openness and care that you might be expressing, not necessarily having arms folded, trying not to scowl at what somebody's saying, but also thinking about the questions that you're asking. So instead of grilling them on the technical points of what they've raised, at least having a short conversation about why what they raised is important to them, which might actually offer you some insight as to what values they're expressing. And then that offers a path, potentially point them towards credible information, asking them about their access to information sources that they might not have thought about. And I think that sort of basic idea of redirection, but also acknowledging what was perhaps really valid in what people were raising in terms of the values that they're bringing into that conversation, that seems to be really important. And importantly, that seems to really resonate. I'll admit, I'm not a clinician myself. And when we first started having these conversations, I was a little bit unsure as to what the reaction to that was going to be. There's potential for the advice that I just offered to sound kind of pedantic. And we've tried not to do that. We've also been really pleasantly surprised that people have found this to be useful. Clinicians are so busy, overwhelmed, trying to do the best thing for their patients. And so pointing out some of these simple ideas has been useful. I also want to point out, though, and this is the third part of the workshop that we emphasize, this isn't the job of any one clinician themselves to do alone. There are individual conversations and opportunities that they have, but it also is an opportunity for our healthcare organizations to think about different roles that they could develop and different opportunities that they might have. And one of those is to think about ways that they might be able to use tools to better monitor the information environments that their patients are encountering. Some of this can happen online in terms of actually scraping and monitoring what's out there in places that many healthcare professionals wouldn't necessarily normally look. It also might be very simple in terms of really having a robust and constantly updated, frequently asked questions section on your website, or thinking about the ways that you gather questions to answer for your patients. And so it may well be an organization level response as well as an individual clinician response.
So it sounds like the goal should not be to convince the patient that what they believe is wrong.
Yes, I think that's really a succinct way of putting it, because there's probably not time, frankly, in a quick exchange. And instead, if you can see the patient, if you can acknowledge them in some way, that might help. And if you can also celebrate that conversation as a victory in and of itself, I think that's also crucial. So there's an opportunity for you to potentially redirect them to more credible information. But there's also something there to celebrate, which is that that patient has brought something to your attention, which means that they trusted you enough to talk to you about it, which means that they aren't off on their own, unbeknownst to you, searching on the internet and just not connected with the healthcare system at all. So actually, we view those challenging conversations as real opportunities for celebration in a way, because it means at least there's a basic relationship of trust between the patient and their clinician that ought to be nurtured and it can be maintained. It would probably be worse, the situation in which you feel like you've never encountered any of this, because then it may well be that you're just not hearing everything that patients are encountering.
Can you talk to us more about ways to reframe the way of thinking about these encounters so that physicians can avoid coming off as scornful or dismissive? And how can physicians be sensitive to cultural factors like race, ethnicity, and religion when dealing with patients who are misinformed?
Right. So I think, generally speaking, we're all human, right? And so it's difficult sometimes to hide our reaction to information or misinformation that we might hear. But if you keep in mind an orientation, just as one would typically in terms of trying to figure out what was going on medically with somebody, the real key here is listening. And the real key is trying to listen and to not necessarily, jump in right away with ideas. And so that turns out to be important. Humility also turns out to be important in terms of not overstating one's own certainty. That can be difficult sometimes, again, if you only have a limited time for an exchange. But generally speaking, I think one important principle to keep in mind is that the patient hasn't come in to try to offend you necessarily or to insult your intelligence, and to essentially try not to take it personally. That they may well, again, if this is an opportunity, it means that they have brought this into you, they're attempting to consult with you as an expert. They might be excited about or have found a lot of information. But again, sort of realizing that it doesn't do anybody any good to necessarily win the momentary argument if people walk out feeling like they aren't going to necessarily trust or feel comfortable raising something again in the future. So it really is a matter of trying to have some patience and compassion in ways that we have so many examples and so much evidence of clinicians doing that and so many other aspects of their everyday care for patients. So the same way that you might think about engagement with somebody around a diagnosis or around other aspects of their life that are challenging, we might also extend into this, because on some level, if somebody is bringing misinformation, it's a problem and it's another opportunity for you to work with and to help the patient. So if you bring the same kind of attitude that you would if they had an earache to something that they printed off the internet, that might help.
And what about those cultural factors like race, ethnicity, and religion?
Yeah. So one of the most important realizations that we've had in terms of thinking about the problem or dilemma of misinformation is that the remedy seems to be rooted in trust, which might seem like a bit of a leap. But I think ultimately what we need is not to necessarily vanquish all sorts of misinformation from all corners of the internet, but rather to get people into trusted relationships with healthcare organizations where they're having informed discussion about this. So there's partnership. Well, that requires relationship building over time. And so, as we think about a dramatic situation where you've got a new pandemic, for example, or a new concern, that's not the time to necessarily just shift right away towards trying to spread information to people. You had to have been building that relationship over time. So I think part of the challenge that we have right now are longstanding concerns, health equity, but also relationships between people and communities and the healthcare organizations that serve them or haven't served them well enough over time. And so I think part of the work that we can be doing when it comes to some of the factors that you just raised is to build now for the next pandemic, build now for the next set of challenges down the line, and to do a better job of trying to make sure that not only are various communities represented in leadership in the different healthcare organizations, the patient voices are a part of discussion. Those things go a long way, not only in terms of other types of planning, but also when it comes to the kind of trust that's necessary for these kind of really challenging conversations. It takes a lot of trust to raise something with somebody that you don't know if it's right or not, and to also trust that they're not going to necessarily be dismissive of you. And so you think about the kind of respect and trust that's necessary. It takes a lot of work to build that into relationships, and it's easy to have that go away. Every time you have a trust building exercise or conversation, realize that you're really making an investment for the future.
Okay, Brian, I am going to give you a couple scenarios.
Okay.
So pretend I'm the patient and you are the physician.
Okay.
And I'd love to hear how you would deal with these scenarios with the teachings you've been telling us about today. Okay. So I am an older patient and I have type 2 diabetes. And I have read online that cinnamon is good for diabetes. So I'm going to take cinnamon pills and I'm going to stop taking my diabetes medications.
Yeah. So there's a lot that could be offered here in terms of advice. The first thing I want to just offer is a really important caveat. I'm not trained as a medical professional, but what I would offer to somebody who is in that situation is the advice along the following lines. So in that situation, you are pointing out a potential remedy that you found that seems to be more attractive to you than the course of treatment that you were on. I'm curious to know, what is it about the cinnamon pills? What is it that's attractive to you about that? Is it a matter of cost or convenience, or what is it that seems to be better for you in that regard? And perhaps then you'd have an answer to that. But that might give a chance of actually understanding, are we really talking about somebody who's desperate for something that is different, more available, differently priced, potentially more efficacious, not going to have the same side effects? And then based on what you raise there, I might be able to point out alternate possibilities within the realm of what I think would be medically appropriate. Or I could point out certain aspects of how the current treatment actually isn't as sort of far off from what people think, or maybe there's different ways to adjust that. So that might be one direction we could go with a conversation like that.
Okay. Now let's do a COVID one.
Okay.
So clinicians are hearing from some patients that COVID-19 has been blown out of proportion and that masks aren't helpful. So how would you advise a physician to respond to a patient that says this? And is it harder when the misinformation comes from the President of the United States?
It's really important, I think, with an infectious disease, that's facing society, to realize that you're behaving not only for yourself, but also for your loved ones and for those that are around you. And that's sometimes you think about the ways in which some of your behavior doesn't just affect you, but it also affects other people. And so that's something I think is really important to point out here. There does seem to be a really important cost-benefit ratio when it comes to something like a mask, where we know that it does reduce the amount of potential contagion that you're spreading back out into the environment. And if everybody did that, we'd be in a much better shape. So it's possible that we could reframe or think about some of these recommendations. If we assume for a moment that everybody's trying to get us to a spot of being better and healthier, and to realize that there's not necessarily an underlying agenda, that there seems to be good reasons why that global recommendation has been out there to wear masks, that's worth keeping in mind. And so I guess that's something that I'm trying to emphasize, is the importance of community protection, and to realize that not all of what's been pronounced politically has been carefully medically informed, and that we're all still learning here, and science works in a way that sometimes we change our minds a bit with new evidence. And so we're really at an early stage where we're trying to figure out what the right answers are, but there seems to be really good evidence in support of community protective behavior.
A lot of the principles you're talking about, it's funny, they remind me sort of just healthy interpersonal communication.
Yes.
Listening, empathy, compassion. These are tricks that you'd probably hear about if you did couples counseling.
There's a lot to be said for that. And yet, why doesn't that happen? Well, I think that in the clinical context, like in many interpersonal contexts, there's a lot of additional stress in a moment where there are not only time constraints, clinicians are busy, but there also is this overarching sense of emotion and stress in the environment. And so I think people have lost sight of the fact that at the end of the day, we've got human beings interacting with one another. And it's important that we continue to see each other in those ways. And I think that that has the potential to go pretty far. And so that's something that we're hopeful that people are going to be able to take a breath, be more compassionate to one another, and to realize that part of the way through this is to not have all the answers, even when what your patient's raising seems pretty outlandish, but to realize that listening to them for a moment might save you a step or two down the line and might be better for all of us together.
So how has your training been received by clinicians?
So something that we've been very excited about has been the fact that these ideas are straightforward, they're common sense, and yet, if you think about what we're asking people to do, it generates additional ideas. So not only is there a way through some of the difficult conversations that people might have, but it also gives ideas for what healthcare organizations themselves might go off and do. So we've had a couple of just anecdotal examples here. One of the people who participated with us earlier this year noted that in her mind, actually, one of the most important uses of our information in the week or so afterwards was an exchange that she was able to have with a fellow colleague. This was not a patient, but rather actually another medical colleague who themselves was actually espousing something that seemed to be problematic. And so thinking about how that conversation might happen, that was really eye-opening and interesting. We also have heard anecdotally an example of a situation where a particular clinic is thinking about developing a tool to help people when they're searching for information online, to then point them to parallel information that's related to their clinic or that's related to their healthcare system. And so people are getting innovative and taking some of these principles and ideas of kind of working alongside patients and helping them navigate their environment. And that's potentially also inspiring new technology developments and new innovation and new strategies. And so we don't have all the answers with our recommendations, but we are hopeful that with this kind of shift in perspective, or maybe reinforcement of a perspective that people realize is really important, that we might get somewhere that's a little bit less polarized and that's a little bit more embracing of patient perspectives.
All right. So what y'all think about that conversation? What he said about the water? He was using an example. Was there anything useful that you could pull from this conversation? He's a communication scientist. And he's talking about COVID-19 conspiracies and other stuff and how to counter the misinformation. So he's trying to put ideas together that can help combat some of the misinformation so that we don't have to work so hard. No, I'm just playing. But I think that was a pretty good discussion and a part of, everything that we've been dealing with all week and leading up to everything. So that's pretty much why I asked what y'all thought about that. All right, so I'm gonna get him off the screen and let's get to the meat and potatoes. Get your pens and papers out because you don't know if a quiz will come of this or some type of questions along the way. But this is part 2 of a lecture we're continuing, and we just gonna get into it with our favorite virologist.
Well, good afternoon. Welcome back. Today we're going to start getting into some nuts and bolts about viruses. We are going to talk about what I call the infectious cycle. So let's first define that. What is an infectious cycle? It's everything that happens from when a virus attaches to a cell and new viruses come out at the end of the cycle. That's the infectious cycle. And sometimes I'll call it the reproductive cycle.
All right, real quick. He just told y'all what the infectious cycle is. When something comes in, goes through, and comes out. He kept it really, really, really simple, really, really quick.
Infectious cycle. So let's first define that. What is an infectious cycle? It's everything that happens from when a virus attaches to a cell and new viruses come out at the end of the cycle. That's the infectious cycle. And sometimes I'll call it the reproductive cycle. Other people call it a replication cycle. They all mean roughly the same thing. So here is a diagram of a generic replication cycle, which shows that we divide it into steps so that we can study it. Many of us specialize in just one of the many steps of the cycle. But of course, in a cell, there are no steps. It all happens in a continuum. We just do that to make it easier conceptually. So here in this theoretical infectious cycle, we start with attachment and entry. And many of these steps we're going to have a separate lecture on, and attachment and entry is one. The virus is attached to very specific receptors on the cell surface, and then they're brought into the cell by pathways like endocytosis. And then that second red arrow is translation. At some point, mRNA has to be made, and it's then translated into proteins. That step differs for different viruses, depending on whether it's a DNA or an RNA virus. As you're going to see, if it's a DNA virus, first you have to make the mRNA. And where that happens depends on the virus. Some viruses go into the nucleus, some stay in the cytosol. But you're going to learn ways to figure out how to sort all that out. And then, of course, if you're an RNA virus, sometimes the RNA is already to be translated. It's an mRNA, but sometimes it's the opposite polarity. So there are lots of different things that can happen leading to translation. So viral proteins are made, and those proteins have a number of functions. They first have to make more viral genomes. they have to do what we call genome replication. And of course, they have to make new virus particles. And that leads to assembly. You take viral proteins, viral genomes, put them together, and then you have release of the virus particles from cells. So that constitutes the entire reproduction cycle or the infectious cycle. And what I want to do today is tell you why this is important, how we study it, some of the methods that we use. But first, a couple of very important terms. I'm a stickler for terminology because, well, I wrote a virology book, and the way you define a word in the first page has to be the same as the last page, right? If you use different definitions, you're in trouble. And so I'm very much a stickler about this. Many virologists are not, but I am. And here are some definitions that are going to be important for you throughout the course. And they will for sure show up on an exam somewhere. And then you'll remember them for the rest of your lives, I'm sure. Susceptible cells. When we talk about susceptible cells, what I mean is the cell has a receptor for the virus. The virus can bind to it. That's all it means. Many other people will say this cell is susceptible to infection and mean much more than I do, but don't pay attention. For this course, susceptible has a receptor. The cell may or may not be able to support virus replication. So on the upper right there, I have two diagrams to illustrate this. It's our infectious cycle diagram. The one on the left, the virus is getting in and going through all the steps, and out come viruses. So that virus can bind to that cell. It's susceptible, but it also is able to support replication, which is not part of susceptible definition. Here's another cell on the right that can just bind virus, but it doesn't produce more virus particles. There's something incompatible inside the cell. That is still a susceptible cell. Okay, a resistant cell simply doesn't have a receptor. And so here, these two cells don't have receptors. Has no implication about what happens beyond virus binding. Again, it doesn't mean anything about whether the cell can actually replicate the virus. It just means that there's no receptor. Now we go to a permissive cell. This is a cell that has the capacity to replicate the virus, whether or not it's susceptible, i.e. whether or not it has a receptor. And here are two examples. These cells are both permissive because the virus is able to go through the entire infectious cycle in it. One has a receptor and one does not. Now you may say, how do we know that there are such cells that are permissive but they don't have receptors? It's very easy. You extract the viral genome from the virus and you introduce it into the cell. We call that transfection. You can bypass the need for a receptor. You're putting nucleic acid in the cell. And for some cells, if you put the RNA or DNA, the viral RNA or DNA in, it will initiate a complete infectious cycle, and that means the cell is permissive. And for some cells, it stops somewhere along the cycle. It's not permissive for infection. The only cell that will take up a virus and allow the entire infectious cycle to occur and produce more infectious viruses is a susceptible and permissive cell. You need both. You need a receptor, which is the susceptible part, and you need permissivity, which means everything beyond the receptor works for that particular virus. A cell can be not permissive for any number of reasons. The block can be very early in the cycle. It can be in the middle. It can be in the late. Doesn't really matter. The point is you don't make infectious virus. Okay, so that's susceptible and permissive. I'll use those often when I talk about viruses, so make sure that you know those. So let's do a little bit of history here. Start at the very beginning. Last time we talked about virus discovery at the end of the 1800s. For many years, people could not grow viruses in cells in culture. We didn't have any cell culture. We had animals and plants and insects in which to grow our viruses, and that's what people did. And here are a host of animals that were used very early on to study viruses. Tobacco mosaic virus, of course, the first virus discovered was studied in tobacco plants. But many of those early human viruses, they were studied in various rodents or even non-human primates. And this was the case for many years, and that really limits what you can do. One of the developments that occurred was the finding that some viruses will grow in embryonated eggs. chicken eggs specifically. So not just the egg you buy at the supermarket. There's no embryo in there, or there shouldn't be. And viruses won't grow in those. But these are fertilized and they're developed to about 10 or 11 days old. And there's a little embryo there in the egg. And you can see on this diagram, you can put viruses in different places in the egg and different viruses will grow. You can see on the right a whole list of different viruses, most of which we haven't talked about yet. But at one point, before we had cell culture, people used to use eggs to grow viruses. And the only one that I'm aware of that people still use eggs for is influenza virus. And here you actually inject the virus into the allantoic cavity. That's this light blue cavity here. It's got about 10 ml of fluid per egg. It kind of is a cushion for the embryo. And it's lined with cells. And so the virus will replicate in those cells. And after a few days, you can just crack the egg open and take out the fluid, and you have lots of virus. I did this for my PhD thesis over and over again because we needed lots of influenza virus. Today, much of the influenza vaccine is grown in chicken eggs. And so there are factories where this is done. There are automated machines that put needles into the allantoic cavity and deliver the virus, and then the eggs are put on racks, they're put in incubators, and then there are again automated machines that withdraw the virus, the allantoic fluid with the virus in it. If you ever got a flu vaccine that's been grown in eggs, they're available from other sources as well. We'll talk about that when we talk about vaccines. About one shot is about an egg's worth of virus, more or less. So next time you get it, you can think, hey, I'm getting an egg's worth of influenza virus here. Now, we also grow the vaccine in cells now, but eggs are still very easy to do in massive quantities. And they use 100, 150 million eggs a year just in the US to make flu vaccine. However, that didn't last forever. There's always progress. In 1949, someone figured out, in fact, 3 individuals, John Enders, Robbins, and Weller, working at Harvard Medical School. All 3 of them got the Nobel Prize for this discovery. They figured out that you could make cultures of cells in dishes and viruses would grow in them. And they did this first for poliovirus and then for many other viruses. So they showed human cell cultures. These are called primary cultures. They were embryonic tissues, and they got them at the hospital, and they made single cell suspensions. They adhered to a dish, and then they could infect them. Nobody had ever been able to do that before. So it was the first time, a really important discovery. They got the Nobel Prize for that in 1954. He's on the cover of Time. Medicine gains on viruses. So this was a revolution because now people could not only study viruses in cells and culture, but it allowed vaccine production. And this was why the first polio vaccine could be made in 1954, the Salk vaccine, and many others following. And so now we use cell cultures routinely. Let me tell you a little bit about cell cultures. We have on the left primary cells. These are human foreskin fibroblasts. And foreskin, you may say, why foreskin? Because they throw it away, right? When they do a circumcision, they throw it away in the hospital. And if you work in a medical center, you can go and get it and use it for your research. You chop it up and digest it with trips and make single cells. And a lot of viruses will grow in them. These are primary, which means you make them from a tissue. But after 10 or 20 or 30 doublings, they die. So they're not ideal. Then we have cell lines here. We have a mouse cell line and a human cell line. This one's the HeLa cell line, a very famous one. And these are cells that started out as a primary cell line, but they became immortal. And we'll talk about immortality of cells in a separate lecture, but they basically can divide forever. So many laboratories use those. We call these continuous cell lines. You can't grow vaccines in these because they're abnormal. They have abnormal numbers of chromosomes. They are transformed. Sometimes we use cell strains that have a limited duration of doublings, but longer than a primary cell. So we use, of course, cell lines in our laboratory. On the left it's a CO2 incubator with various plates and 6 well plates and small plates and flasks full of cells. And in these configurations, these are plastic disposable dishes. They're covered with medium, and the cells are adhering to the bottom. They stick to it. So when you take the medium off, the cells are stuck to it. You can put your virus on and so forth. If you need a lot of cells, you can grow them in what are called spinner cultures. So we at one time used very many HeLa cells to do plaque assays, as you'll see. And so you grow them in like a liter with a magnet spinning at the bottom in a warm room. And you can grow many, many, many billions of cells this way. Of course, HeLa cells were made in the 1950s by taking a piece of a tumor from a young lady, Henrietta Lacks in Baltimore. And that tumor piece was subsequently put into cell culture and ended up dividing forever, the first time that it ever happened. And this, of course, is a book that is all about it by Rebecca Skloot. Her kids didn't know this. She died a few years later. Her kids found out many years later, and they were kind of outraged that her cells had been taken and no one told them. So there's a book about it, there's a movie and so forth. But early in the preparation of this book, Rebecca Skloot emailed me, and I helped her to get the science right in it. So it was a lot of fun working with her. Nowadays, besides cell cultures, we still use them. We have all kinds of other amazing ways, because the cell in culture is pretty far removed from an animal, right? We're trying to get closer and closer to it. And here's 2 ways that we can do that. On the left, organoid cultures. We can approximate the structure of specific organs using these cultures. There are 2 ways you can do it. One, you can start with a blastocyst and take out the inner cell mass. These are called embryonic stem cells, and they can be differentiated into different organoids depending on the treatment you give them. Because, of course, these cells are pluripotent. They eventually differentiate to everything. So you can make gastric organoids, liver, et cetera. And depending on what virus you're working with, you might want to make one or the other, depending on where it's replicating. On the bottom, you can also take a somatic cell and make it pluripotent. It's amazing technology. You take any somatic cell, you could take a skin cell, introduce a few plasmids into it that produce different transcriptional regulators. It will now become a stem cell, and you can differentiate that into organoids as well. So organoids are really revolutionizing virology. On the right are what we call air-liquid interface cultures. The epithelium that lines the respiratory tract, in fact, all of your mucosal layers, is very special. It's exposed to the atmosphere. So it has an apical side that's exposed to the air, and then the basolateral is adjacent to tissues. And you can approximate that by first taking cells, say you could take it from a human biopsy of the lung or from a mouse or other animals, and you can make a monolayer of those in these very special wells where they're sitting on a membrane that's permeable. And then you have liquid on top and on the bottom. You wait till they're confluent, that is, all the cells are touching each other. Then you remove the liquid on the top only, and they go, air, and they differentiate. They think that they're back in the lung where they came from, and they become mucosal epithelial layer with all the different cell types, the ciliated epithelium, the mucus-producing cells, and so forth. So those are called ALI, and they're very powerful as well. A lot of cool things you can do with cell culture. Time for a question. It is a blank and blank cell is the only cell that can take up a virus and replicate it. So there go the question.
I'm gonna give y'all time to answer. A blank and a blank cell is the only cells that can take up a virus particle and replicate it. Fill in the blank. Put your answers in the chat. You can put A, B, C, D, E, or F. Come on now. Put your answers in there. Let's go. We building. We learning. Even if you don't know, even if you don't know, just put you don't know. Don't guess, just put you don't know. Don't do the majority rule vote. You know what I'm saying? Now you good, overstand. I'm saying if you can't answer, you know, you can respond. If you can't, it's cool too. Let's see what the answer is.
Here are the choices for the blank and blank. Naive and resistant, primary and permissive, susceptible and permissive, susceptible and naive, continuous and immortal. How do we do? 100%. Wow, that's
You gotta remove the comment because they can't see the answer. It's still on here.
Oh, my bad. I didn't even try to do it.
Oh, no, you good. You did it again though. Yeah, there you go. So there it is. It's A blank and blank cell is the only cell that can take up a virus particle and replicate it. Fill in the blank. If you don't know, it's okay to say you don't know. You know what I'm saying? We're learning. We're on this path together. This is going to make us more, studied when it comes to viruses, how they act, understanding COVID-19 and other pathogens that exist or may exist in the future. This is also our college level information and courses that we could turn around and we can, you know what I'm saying, pass down to our youngins. But it is recorded and we got it and we can refer to it when necessary.
It's 2 days in a row. Very impressive. Okay, good. That's right. Susceptible and permissive
C
is correct.
So the answer is C, susceptible and permissive. So a susceptible and permissive cell is the only cell that can take up a virus particle and replicate it. A susceptible and permissible cell is the only cell that can take up a virus particle and replicate it.
All right, so we have cell lines, we have organoids, we have really cool things to study viruses in. First, let's answer a couple of questions. First of all, how do you know if the cells are infected? I give you a nice monolayer, you put virus on, how do you know that they're infected? And there are a couple of ways we can do that. One is by simply looking at them in a light microscope and looking for what we call cytopathic effect, CPE. And that is changes in the cells that are visible through a light microscope. And so here we have pictures of HeLa cells in culture that are infected with poliovirus. On the upper left is the monolayer before it's infected. Lovely monolayer. All the cells are touching each other from one side of the plate to the other. And then we infect it. We take off the medium. We add a small volume with poliovirus in it. We let the virus attach. And then we add fresh medium, and then we incubate. And on the top right, something like 4 hours post-infection, 8 hours, and 12 hours. And I think you can see things are happening here. It's obvious to you. On the upper right, some cells appear to be rounding up Right? There are gaps in the monolayer now, and by 8 hours, most of them are rounded up, and by 12 hours, a lot of them have broken or lysed. So that's one form of cytopathic effect. You could look at your culture and say, my cells are clearly infected. Now, let's say you're working with a new coronavirus in China, right? You have a little nasal wash from a patient with pneumonia, and you want to see if there's some virus in it. First thing is you have to figure out what cells to use. And so there's some history there with coronaviruses. So you get the right cell and you put the virus on, and then you look at it every so hours. And if you see some CPE, it looks like the virus is replicating. There are many kinds of CPE. Here's another one. So the one I showed you was cells rounding up and lysing. Here's one where the cells fuse. So this is infected with viruses that induce the formation of proteins on the surface of the cells that cause the cells to fuse. We will explore why this happens in a bit in another lecture. But here, basically, on the upper left there, that cell is making a viral fusion protein with it's the red Y. And that binds to a receptor on a neighboring cell and induces the two to fuse. So we'll now, where we had two cells, we have one, and these can fuse with many other cells. And you can have what we call giant cells with multiple nuclei, or syncytia. That's what this is called. And here's a light micrograph of this phenomenon. These are single cells, you can see, and in the middle is a big one with multiple nuclei. That's the one with the black arrow. There are a number of viruses that do this, including measles virus, cause fusion because they have a protein encoded in their genome that does this. So here's a summary of different sorts of CPE for different viruses. I don't need you to remember any of these specifically. All you need to do is that cytopathic effect, are the visible changes in cells that occur when viruses infect them. And you can see, depending on the virus here on the right-hand column, you get all kinds of different things happening. Syncytium formation is there. I showed you that. What else did I show you? Rounding up and detachment of cells, right? I showed you an example of each of these, but there are other things: nuclear shrinking, vacuoles, virions in the nucleus, ribosomes in the cytosol, and so forth. So some of these are more subtle than others, and some of them are actually specific for a virus. In the old days, before we had rapid diagnostic methods, people could actually look at tissue sections and have an approximation of what was infecting you. We don't need to do that anymore because we can do PCR, which is faster and more specific. But at one time, this was diagnostic. And today, again, if you're working in the lab growing your virus, you use this to say, my infection is working or not. All right, so that tells you how you know that your virus is replicating. So now your experiment is over. You've taken the supernatant of the cells. We centrifuge away all the cells after the infection's over. We have a supernatant. Now you can put that supernatant into little tubes. As you see here, we like to put liquids in small tubes and label them and freeze them and so forth. But then you would like to know how much virus is there, because if you're going to do subsequent experiments, you need to know what we call the virus titer, or how much virus is present. So there are two ways that you can do this. You can measure infectivity, or you can measure physical properties, particles and their components. So I want to give you an idea of both kinds of assay. The most important in my view is the infectivity, but sometimes you can't do that. So we'll talk about both of them. We'll start with an assay called the plaque assay. And this was first developed in the 1930s to study viruses of bacteria, bacteriophages. Now, when the first bacteriophages were discovered in the early 1900s, they immediately had a plaque assay to study them. That's how they were first found, that the phages caused clearing on bacterial lawns, as you can see here. But it wasn't until the 30s that they were used quantitatively. So here is a plaque assay of a bacteriophage. This is essentially an agar plate on which there is a lawn of bacteria growing, and where you see each of those clearings, that's where a bacteriophage has made a zone of lysis. And this is the kind of thing you can do in high school. It's pretty safe, so a lot of people get their first experience with viruses in labs with bacteriophages. So each of those circles And I'll explore this for you in some detail in a moment. Each circle is caused by a single virus starting an infection of a cell, which then breaks open and the infection spreads until the clearing is big enough for you to see it. And then you can count these and calculate the titer of the virus in what we call plaque-forming units per milliliter. In the 50s, it was developed for animal viruses by Renato Dulbecco. Here's the paper he published. He was at Caltech, 1952. The production of plaques in monolayer cultures by single particles of an animal virus. And here's one of his pictures in the paper. So he took what we knew about phage plaque assays and he converted it for animal viruses. Of course, it's a totally different assay because here we have a monolayer of cells and there's no agar on which the cells are growing and so forth. But he ended up getting it to work for them and he got a Nobel Prize in 1975. So here's how a plaque assay works. So I give you a tube of virus. That would be our virus stock there, all the way on the left. You make 10-fold dilutions. You take phosphate buffered saline, you put 0.9 mLs of that into a bunch of tubes, and then you take 0.1 ml of your virus stock, you put it in the first tube, you mix it up, take a 0.1 ml out of that, et cetera. You go all the way down the line. We call that serial 10-fold dilutions. And so then you will have -1, 2, 3, 4, all the way out to -7 or whatever you do, depending on how well your virus grows. And then to do the plaque assay, to do the titration, and the reason you do these dilutions, of course, is because you don't know exactly the titer of the virus. It could be 10 to the 3 or it could be 10 to the 9th per mil. So you do a range of dilutions. And then you take 0.1 ml typically and plate that on top of a monolayer of cells. So you have cells growing in culture, you remove the medium, you put 0.1 ml of your virus dilution, you let the virus attach for typically an hour at 37 degrees. And then you add an agar overlay and put it back in the incubator. And what will happen is you will get plaques, just as we did on the bacteriophage plate, except these are now animal viruses making holes in the cell monolayer. You can count them and see, for example, we have a -6 dilution here. We have plated out 0.1 ml. So that's a total of -7 in the dilution. We have 17 plaques. So the titer of the virus is 1.7 times 10 to the 8th PFU per ml. 17 plaques on a dilution of 10 to the -7. It's very simple calculation, nothing fancy about it. Let me tell you a little bit about how the plaque assay works. So here on the top is a depiction of it. We have a plate of cells growing in a small dish with medium on top. The cells are side to side, as you can see in this blow up. When a virus infects a single cell, that cell is already lysed here in the middle. So one cell is infected. That cell releases viruses. They infect neighboring cells, and those release viruses, and they infect more cells until the clearing gets big enough that you can see it. The agar is important because it restricts the diffusion of the virus. If you had liquid on top, the virus would spread throughout the culture and every cell would be infected in lice. You wouldn't be able to count plaques. So agar is a key part of the plaque assay because it restricts the movement of the virus. Now on the bottom left is a light microscope image of a single plaque. So this is rather high magnification. And you can see the cells of the monolayer. And in the middle, the cells are rounded up and they're dead. They're killed by the virus. That is a single plaque. Sometimes viruses don't kill cells and you can't do a plaque assay. And one solution is you could put a gene into their genome that makes a color. And here on the right is a virus that makes a blue color. So you don't have to worry about the virus killing the cells. You can just count blue plaques instead. So there are lots of ways you can get around that. Now here is a movie of the formation of a plaque. This is a time-lapse movie. It's going to cycle. What they did was they infected a monolayer and they found a single infected cell, and then they focused the camera and took a frame every minute or so. And the upper left, you can see it goes up to 15 hours total. And what you see happening is that initially the infection is small and then it spreads. And that's as cells are lysing, they're releasing virus, they're infecting new ones and spreading out. It's sort of like dropping a pebble into a pond and making a ripple. So the plaque is getting bigger and bigger. This movie was made about 10 years ago, just at the beginning of when I started teaching. And it just is a beautiful way to illustrate what's going on. This is the greatest movie ever made, in my opinion, because I think the plaque assay is just the best assay ever devised. Now, we do a lot of plaque assays in my lab, and this is one result of one of them. I had a person in my lab 5 years ago. She did an experiment with 1,600 6-well plates. It was all one experiment. She did plaque assay, and I decided to keep them and make a wall, and we call it the wall of polio. These are some students from the class last year who had come for the last office hours. So if you come for office hours, you can see this work of art. It's really magnificent. It goes from floor to ceiling. 1,600 and some plates, the wall of polio. I know you think I'm crazy, but I think the plaque assay is amazing, and why not make a wall out of it? Okay, we have a new question here. Okay, when doing a plaque assay, what's the purpose of adding a semi-solid overlay on the monolayer? So A, to stabilize particles. B, ensure the cells remain susceptible and permissive. C, to act as a pH indicator. D, to keep cells adherent to the plate during incubation. E, to restrict viral diffusion after lysis of infected cells. Okay, how did we do? So most of you got the right answer, which is E.
Target. I tried to catch it before he gave up the answer. The question is, when doing a plaque assay, what is the purpose of adding a semi-solid agar overlay on the monolayer of infected cells? Is it A, to stabilize progeny virus particles, B, to ensure the cells remain susceptible and permissive, C, to act as a pH indicator, D, to keep cells adherent to the plate during incubation, or E, to restrict viral diffusion after lysis of infected cells? Yeah, I kind of let that one ride out. So y'all got away with that one. Y'all got away with that one because I hit my button, but it didn't hit the mute in time. Dang cheaters.
To restrict viral diffusion after lysis of infected cells. Remember, if you have a liquid overlay, not an agar, this virus will diffuse everywhere and infect all the cells. So that's the purpose of the agar overlay. It's not to keep the cells adherent. The cells will adhere under a liquid overlay. That's how you grow them. Now, an important question to answer is how many viruses are needed to form a plaque? Because if you're going to measure the virus titer by a plaque assay, you have to make sure that one virus will make a plaque. And this is a relatively easy question to answer. You do a dose response curve. What does that mean? Well, you take your virus and you make different dilutions of it and you do a plaque assay. So here that's graphed. On the x-axis, we have virus concentration. So it's going from low to high. And on the y-axis is simply the number of plaques. That's what a dose response curve is. And according to mathematical principles, if you need one virus to make a plaque, you should get a straight line because that's one hit kinetics. The number is proportional to the concentration of virus. And that's what you see in the red line here. So for many viruses, this turned out to be true. Some viruses actually have two hit kinetics. You need two particles to infect a cell because the genome is packaged in two particles and not one. For most viruses, the genome comes in one particle, but for some it's in two. They both have to infect the cell. So you get two hit kinetic, number of plaques is proportional to the square of the concentration. You get this kind of a curve here. So that's how we know that one plaque is formed by one virus. Plaque assay is also useful for cloning viral stocks. and I use cloning in the old word before recombinant DNA. If you have a plate of cells where you've done a plaque assay, you can often visualize the plaques by holding it up to the light. You can circle one with a marker, and then you can go back into the hood, take a pipette and plunge it into the agar. You now have a little agar plug above the plaque, which has virus in it. You can put that into a tube of PBS, and then you could repeat this 2 or 3 times more. And this is our way of purifying viruses, say from a clinical isolate, to make sure that you have one virus that you're starting with. It's called plaque purification. As I mentioned earlier, some viruses don't kill cells. You can't do a plaque assay. There are other ways that we can measure virus titer, and this is one of them. It's called endpoint dilution assays. And what we do here is we take a 96 well plate. Each of these wells has a monolayer of cells in it. And we plate dilutions of viruses here from 10 to the minus 2 to 10 to the minus 7 from top to bottom. We just do replicates across the well to the plate to the right. So the first line gets all minus 2, the second gets all minus 3, etc. So you infect these cells with that dilution. You add your liquid overlay. Now we're not counting plaques because this virus doesn't plaque. And then you incubate and you see which cells are killed by infection, which cells show CPE, and then you score it. And that's what's shown here. So let's say after 2 days of incubation, you score cytopathic effect, and very simply, plus if there is and minus if there isn't. And you can see at the very low dilutions, all the cells show CPE. So that tells you there's probably a good amount of virus here. And then as we get higher and higher dilutions, you see you get more and more minus, no CPE until 10 to the minus 7, there's none. And then you calculate the dilution at which you get half of the wells showing CPE. And that would be the 50% infectious dose then, or infectious titer. And that on this particular experiment, that's 10 to the minus 5. You can see there are 5 pluses and 5 minuses. Often it doesn't fall exactly like that. There often is a mixture, but you can use math to interpolate the infectious dose 50%. So this is done often for viruses that do not make plaques, or for people who don't want to do plaque assays. Sadly, there are some of those in the world. They would rather do this than a plaque assay. I don't understand it. Another key concept is that not every virus particle that is made by a cell is infectious. Some of them are broken in many ways. And we can quantify this by what we call the particle to PFU ratio. And that's shown in this table here. It is simply the number of physical particles divided by the number of infectious particles. So the bottom, the denominator, we can do by plaque assay. We can figure out how many PFU there are. The top, you have to do some kind of physical measurement. You can count particles in an electron microscope. You can do spectrophotometric measurement. But the point is, you divide the two and you get a particle to PFU ratio. And on this table, you see that viruses have a big range in their particle to PFU ratio. Some, for example, down here, Semliki forest virus, almost every particle is infectious. It has a particle to PFU of 1 or 2. And that's very interesting. That it seems to be very robust. But other viruses are less so. Here, for influenza virus, for every infectious particle, there are 20 to 50 non-infectious particles in any preparation. In some viruses, they're 10,000 to 1. So viruses vary in the number of defective viruses that they make in any infectious cycle. And this is very important, of course, because if your virus has a very high particle to PFU ratio and you're looking at infections biochemically, you don't know if your signal is actually the infectious or the non-infectious population. So it's very important to consider. This one hit kinetics of a plaque formation, that tells you that a single particle can initiate an infection, right? One hit means a single particle can, but from the particle to PFU ratio, we know that not all viruses are successful at doing that. You wouldn't find that out in the one hit kinetic curve. Why is that? Sometimes particles are damaged as they grow in cells. Biology isn't perfect, as you know. On the right is an electron micrograph of a preparation of polioviruses. And you can see there's some there that look empty, right? They're just a shell. They're shells of their former selves, and those are not infectious. One of the reasons is that they're broken during assembly and don't get RNA in it, or they lose it later on. So they're damaged. Genomes can sustain mutations. Another reason I like to think is that, the infectious cycle, you have to attach, the virus has to get in, has to translate into proteins, has to replicate its genomes, et cetera. Every step has to occur in order for the whole cycle to finish. And if you stop at any one step for whatever reason, you don't get a virus particle. So that could be another reason as well. As I mentioned earlier, this complicates the study of viruses because you never know if every virus you're looking at is infectious. But that's an important concept to understand, that in any preparation of virus, not all are infectious, and it varies according to the kind of virus you're working with. All right, our next question is, in this particle, the PFU ratio, particle can best be described as one of the proteins which makes up the virus, a virus which may or may not be infectious, a virus which is infectious, a virus which is not infectious, elementary or composite. Okay, how did we do? Right, a particle which may...
I can give y'all the answer for this. And the particle to PFU ratio, particle can best be described as A, one of the proteins which makes up the virus, B, a virus which may or may not be infectious, C, a virus which is infectious, D, a virus which is not infectious, E, elementary or composite. We ain't doing no guessing, no. This is it. I do. This is, look, watch this. Yeah, I caught it. I almost didn't catch it responding to fits. But in the particle to PFU ratio, particle can best be described as A, one of the proteins which makes up the virus, B, a virus which may or may not be infectious, C, a virus which is infectious, D, a virus which is not infectious, E, elementary or composite. Nobody better say E.
May or may not be infectious. The numerator can be either one. The denominator is infectious. So the numerator is everything. All the particles in a prep, infectious plus non-infectious. The denominator is infectivity. That's where you get this particle to PFU ratio. Another key experimental tool is what we call the one-step, may or may not be infectious, PFU ratio particle. Viruses, because you never know if every virus you're looking at is infectious. But that's an important concept to understand, that in any preparation of virus, not all are infectious, and it varies according to the kind of virus you're working with. All right, our next question is, in this particle, the PFU ratio, particle can best be described as one of the proteins which makes up the virus, a virus which may or may not be infectious, a virus which is infectious, a virus which is not infectious, elementary or composite. Okay, how did we do? Right, a particle which may or may not be infectious. The numerator can be either one. The denominator is infectious. So the numerator is...
The answer was B. I was trying to let y'all catch it again. But the answer was B.
It's everything. All the particles in a prep, infectious plus non-infectious. The denominator is infectivity. That's where you get this particle to PFU ratio. Another key experimental tool is what we call the one-step growth cycle. We talked about this a little bit last time. I want to explain it a little more and tell you why it's useful. This was developed in 1939 for the study of E. coli bacteriophages. And what you do, in this case, you take your bacteria, you add your bacteriophage solution, you let the bacteriophage absorb or attach to the bacteria, then you dilute the culture to stop the new infections, and then you incubate it and you measure the production of virus at different times after infection. And so by adding the bacteriophages to the bacterium, you're synchronizing the infection, so all cells are infected, and then you dilute it to stop the infection. And so what happens here is that you get this typical curve where we're looking at time versus the number of particles made. You see there's an eclipse period where we don't see any infectivity. So we take time points every so often here. We do a plaque assay. And for the first time, whatever it may be, it could vary for different viruses. It could be minutes or hours. There's no virus, infectious virus detectable. We call that the eclipse. And then suddenly at some point, viruses, infectious viruses start to be produced until the cells are all destroyed and no more can be produced. And then the production plateaus. So this is called the burst or the yield of virus. That's what's produced during this infectious cycle. That is a one-step growth cycle because all the cells are infected, they all produce virus, and then they're all killed. One step of infection. There are things happening here in this early period. The RNA, the genome is out of the particle, it's in the cell, mRNA is made, translation is going on, proteins are being made, but you do not detect virus, infectious virus. Right? But since this was done first in 1939, they actually didn't know about mRNA and all that. They just saw that there was a lag. They figured something was going on, but they didn't know what. Now that is a one-step cycle. Every cell is infected. And this is extremely valuable for studying the properties of your virus. I've been looking for a one-step curve with the new coronavirus. Nobody's published one yet, but I'm expecting one in the next few weeks. And I will show it to you when someone does it because you'd like to know what cells this virus can infect. What's the kinetics? Is it fast? Is it slow? Does it make a lot of virus? So forth. Very interesting questions. And if you make mutants, if you have antiviral drugs, you will use a one-step growth curve to test the drugs to see how they affect virus production. So an incredibly powerful assay. You can make it multi-step by using less virus to begin with. So here on the right is a multi-step growth curve. You dilute the virus so you're infecting fewer cells to start. You still have an eclipse period. You have the first burst where not all the cells are producing virus, just a fraction of them. They make virus, that goes on and infects more cells. You get a second burst. And depending on how dilute you make it, you can have multiple bursts. This can be useful if you don't see a difference in a one-step growth curve and you want to make sure that there is something going on. You can do a multi-step, and typically it's more sensitive to, say, antiviral compounds. So that's the one-step growth cycle for a bacteriophage. Of course, we can do these with animal viruses. Here's an example with an adenovirus, which is a big DNA-containing virus that we'll come back to many times in this course. Again, you take your cells in a plate, take the medium off, add virus, let it absorb, put medium on, and then sample the medium at different times after infection. So that's the x-axis is time, y-axis PFU per mil. And again, you see an eclipse period where there's no infectious virus in the medium, and then viruses start to be produced. And then again, they peak. Now here we have a little extra step added where we're measuring extracellular versus intracellular virus. So what we can do is take a little sample of the medium where the viruses are coming out into from the cells. We can do a plaque assay on that. That's extracellular. Then we can take the cells themselves and break them open and ask how many viruses are in them. Obviously, to do that, you need to have multiple samples, one for each time point. And if you look at the intracellular, which is red, you get an eclipse and you get virus production. But if you look at extracellular, this period of no virus lasts longer. See, another time point. And that we call the latent period. That's the time when there's no virus released from the cell. You can't find it in the cell supernatant. So the eclipse is when you look inside of a cell and you don't see virus particles. And as we said, that's the time when the viral genomes are being made and translated and so forth. The time it takes for the virus particles to get out is the latent period. So there's a lag between making an infectious particle in a cell and the time that it gets out. It either has to break the cell open or get out by some other means, as we'll see later. Okay, so that's a growth curve for an animal virus. And remember, this is fundamentally different from bacteria, because bacteria divide by binary fission, right? You put one bacterium in a culture, it divides to 2, 4, 8, 16, and so forth. And viruses are fundamentally different. They make the parts and then assemble them. And I said that last time, and someone watched the video on YouTube and they put a question in there. I don't think it was one of you, but it's okay if it is. And they wrote, why do viruses have to make the parts and then assemble? It's a why question, first of all, because we can never answer why questions in biology, but I will anyway. You can't say why, because why is a philosophical question, right? You could say what's the mechanism of or the outcome of. It's the way they do it. That is what a virus is. It makes the parts. A virus can't divide. It can't, because it's not alive. So it has to do it another way, and that's by making the parts. Now, a key to this, yes. You mean the incubation period in a person? Like if I give you a coronavirus and it takes you 10 days to get sick, that's the incubation period. No, it's different, because during that incubation period, you're having multiple cycles of viruses infecting cells and being released. And it's only when the virus gets to a certain level in a person do you get disease. So yes, it's longer than this eclipse period, yes. And the incubation periods are very interesting. We'll talk about it later, but let me leave you with a thought. For some viruses, for some virus infections, viruses shed during the incubation period. For others, it's not. And we suspect for this new coronavirus, it is being shed during the incubation period. In contrast, during Ebola virus infection, you do not shed until you are sick. Very different. So much easier to control the spread of an Ebola infection, because you can see that a person is sick. The corona person get on a plane and go around the world and not be sick, and then get somewhere and get sick. Well, we'll talk about that later. So it doesn't correspond to that period. To do a one-step growth curve, you have to infect all of the cells. That's the key. So they're all doing everything in synchrony. So now the question is, how do you know that all the cells are infected? All right, we have to infect every one of them. And there is a way to know that, and it's called the multiplicity of infection, MOI. This is a term that I'll use a lot. It is the number of infectious particles you add per cell. And it's very easy to calculate. You just take the PFU that you add and divide by the number of cells in your experiment. It's not the number of particles that each cell gets. That turns out to be different. So for example, if we add 10 to the 7th viruses to 1 million cells in a plate, that's an MOI of 10. So MOI is simply what you add as an investigator. What the cell actually gets is different. Each cell doesn't get 10 virus particles. That is determined by a statistical distribution. Okay, so this is very important. The MOI allows you to control how much virus you add to a cell, but the number of viruses each cell gets is very different. And here's the idea. Infection is a random event. You put viruses on cells, and the collision is random. And some cells will collide with none, some will collide with 1 or 2 or 3 or more. It's like taking a box of tennis balls. If I had a bunch of buckets here and I threw the tennis balls into them, not every bucket would get 1 ball, right? Even if I had, say, 10 balls and 10 buckets, some would get none, some would get 1 and more, and so forth. Same thing with virus infection of cells. And that distribution per cell is described by the Poisson distribution, which is shown here, and many of you have encountered before. It's a bell curve that describes the number of virus particles that any cell would get depending on how much you add, depending on the multiplicity of infection. And here's the equation for the Poisson distribution, where pK is the fraction of cells that are infected by K virus particles, M is the multiplicity of infection. So we can really simplify that, and that's shown at the bottom here. So uninfected cells are described by this equation, simply e to the minus m, natural log to the minus m. M is the multiplicity. And those would be uninfected cells at this, say, multiplicity of 10. You just plug 10 into here, and that would tell you how many cells are uninfected. Cells getting one particle would be me to the minus m. M, again, is multiplicity. And then getting multiply infected more than one is this equation, which is made by subtracting from 1, which is the sum of all probabilities for any value of k. The probabilities p0 and p1. So you take those two, you subtract them from 1, and you get the number of multiply infected cells. This is a lot easier than it sounds. So let me go through a couple of examples for you. So here, if you take 1 million cells, we have 3 plates here with 1 million cells each. And if we infect at a multiplicity of 10, you could take that formula I just showed you, and it will tell you that 45 cells are uninfected. So that's why you can do a synchronous infection. Basically, you're infecting all of those million cells in the dish. So an MOI of 10, turns out 5 is good too. So if you want to do a one-step growth curve, an MOI of 5 or 10. The rest of the cells, aside from these very small numbers, get more than 1 particle. If you use an MOI of 1, it's slightly different now. You get 37% of the cells are uninfected. 37% get 1 and 26 get more than 1. So basically 37% uninfected. You could do maybe a 2 or 3 step growth curve there. And then if you use an MOI of 0.001, 99.9% of the cells are uninfected. And so that would be a really multi-step growth curve if you wanted to do a long-term study of the effect of a mutation or a drug. All right, so that's multiplicity of infection. Again, we can calculate it for any amount of virus that we put on a cell, and we can establish conditions for a one-step growth curve or a multi-step growth curve. If cells are infected at an MOI of 10 in a one-step growth curve, you will see multiple bursts of virus release, multiple eclipse periods, a single burst of virus release, no burst, or asynchronous infection. If you wanted to do a one-step growth curve with your new coronavirus, you'd have to titrate the virus first to make sure you had a high multiplicity of infection on your cell cultures. And hopefully people are working on that right now.
If cells are infected at an MOI equal 10 in a one-step growth cycle experiment in the growth curve, you will likely see, y'all got the answer, man. Y'all got the answer. It just shows. What's the answer to it? A, multiple bursts of virus release, multiple eclipse periods is B. A single burst of the virus release. D, no burst of virus release. A, synchronous infection. E. Thurman said C. Gary said A. Y'all started to pick up on the things. What else? What Cherry said? Cherry said A. Oh no, that was to the last. Nunu said A. Cause y'all just heard him say this. He just said it. When he was here. I know y'all can't see it on the screen, but you know what I'm saying? A little red arrow had popped up. Cherry says C. That's it? All right. Everybody else get the answer.
All right, let's see what we did. Single burst of virus release. Most of you got that. It's an MOI of 10. Remember, I said 10 was good for a one-step growth curve because if you look at the Poisson, most of the cells are infected. So you're going to get a one step when you infect all the cells.
I'm going to speed it up.
37% get one and 26 get more than one. So basically 37% uninfected. You could do maybe a 2 or 3 step growth curve there. And then if you use an MOI of 0.001, 99.9% of the cells are uninfected. And so that would be a really multi-step growth curve if you wanted to do a long-term study of the effect of a mutation or a drug. Most of the cells are infected. So you're going to get a one step when you infect all the cells. Multiple cycles, you will only get at a low MOI, 1 or below. Okay, so those are using infectivity to measure virus titer and some of the ways we can control a one-step growth curve. Let's look at a couple of physical measurements where our virus doesn't form plaques. You've tried as hard as you can, and you can't get it to form plaques. And so now we need to do other things. And I'm going to talk about 5 different categories shown here. We can use red blood cells in a process called hemagglutination. You could actually use electron microscopy to count the particles, but nobody does this because it's rather tedious. Although I know for the new coronavirus, an electron micrograph has already been published from one of the first patients who took a little bit of wash from the respiratory tract, put it under an EM, and you can see what looks like a coronavirus particle. So when you're finding a new virus, it can help because we know more or less what a virus of a certain family looks like. Some particles have enzymes in them that we can measure. We can use serology, which means antibody-based tests, and we can use nucleic acid-based tests. So let's go through some of these. Hemagglutination is a really interesting assay, which is used mainly for influenza viruses. And the idea is that the receptor for influenza viruses turns out to be a sugar, sialic acid, that's on red blood cells. You could buy chicken or guinea pig red blood cells from suppliers, and the virus will attach to them. It doesn't infect, but it attaches and it makes a lattice. And you can see this lattice within 30 minutes. So it's a really quick way to get an estimation of how much virus you have. And what you do is you make here 2-fold dilutions of your virus and mix them with red blood cells. And then you let the red blood cells sit there for half an hour at room temperature. And if there's no virus present, all the red blood cells fall to the bottom of the well and they make a little button. See that? If there's virus present, the lattice coats the side of the well. So the red blood cells are all stuck together so they can't fall down to the bottom. And you can see this goes out to about 1024. So I would call that an HA titer of 512. So that's hemagglutination. And again, when you grow influenza viruses, before you do your plaque assay and wait a couple of days, you could do this and find out very quickly. Some viruses have enzymes in the particle. Retroviruses are a great example. Here's a diagram of a retrovirus. We'll talk a lot about these viruses in this course. This includes, of course, HIV-1 and others. The particle, besides the genome, shown here in green, has an enzyme called reverse transcriptase, which takes RNA and makes a DNA copy of it. And you can measure that very readily. Here on the right is an assay for reverse transcriptase, where you take the supernatant of infected cells, you filter it through a piece of nitrocellulose here, and beforehand you have thrown in radioactive triphosphates, which get incorporated into the DNA product made by RT, and you can see that this particular infected culture is making increasing amounts of product over time. So very easy to assay the reverse transcriptase for these viruses.
Hey, real quick, what is this? What's this right here? What are we looking at right here? Anybody know what we're looking at right here? And if you know what we're looking at, what type is it? All right, peace to you, Brother Gary. Yeah, it'll be available, man. Let me know what you think. Leave a comment or something when you get to the point. But yeah, we're almost down to the end, the last stretch. I want to know what this image is right here. Right here, this. what I'm circling. I want to know what this image is. And if you know what it is it a type? Which type? This thing I'm circling right here, Nunu. Look at it very carefully. You got to know what this is. You're talking about those idle shares right there when you say spike. But what is this whole thing right here, this whole picture? Thurman, what kind of virus? What kind of virus is it? And yes, those are spikes. Yeah, but I'm talking about the whole thing. This whole image. What is that? Oh man. Oh man, Mel done snuck in here, man. He done missed the questionnaire, both questionnaires and class. Even though he know these answers. It's over now, man. You know what I'm saying? Mel that came in here and shut it down. Now, Jerome did answer. Jerome answered it too. That's the coronavirus. This is you know, an artistic expression of the coronavirus. You know what I'm saying? And we know how it look. Excuse me. We know how it look because they have an image of it. And they see the spike proteins, right? And they know how it look, and you know what I'm saying? So earlier on when they were developing the vaccine, the vaccine for it, those are the things that they were actually looking for. But yeah, Malcolm is just going all the way into it. He dealing with the whole, you know what I'm saying? I just wanted to throw my own little quiz in there on y'all, see who paying attention.
Viruses, most of which do not form plaques. You can use extensively serology, and one of the formats is an ELISA enzyme-linked immunosorbent assay for looking for viral antigens or antibodies. You can, and they're both shown here. So here we have this should be capture, not captured. It should be capture antibody because this is an antibody that you have raised against your viral protein. And now you take, say, nasal wash from a patient. You take a piece of plastic dish where the antibody is attached to it. You put the wash on top of it. If there are viral proteins present, they will be captured by the antibody. And then you use a second antibody to detect the viral protein. And you can use an antibody that's labeled with a fluorescent indicator or something else. And these are the basis for rapid diagnostic tests that are being increasingly used. And these are being now developed for the coronavirus so that we can do rapid diagnosis rather than wait a couple of days for PCR. The other way you can do this as well is you can put the viral protein on the plastic. You add serum, and you're asking, are there antibodies to this viral protein? You use a second antibody to which is conjugated some kind of indicator. And so serological surveys where we take people and take blood and say, do you have antibodies to this virus, are very important for telling us who's been infected. Because not everyone is sick, but they might have been infected and been asymptomatic. And so you would like to know, for example, what % of people in an outbreak of the new coronavirus are actually infected versus those who are sick. I have a suspicion that a lot of people are infected but are not sick. And a serological survey will tell us that, where we put their serum on this kind of a format assay. And it will take more time to get that kind of information, but it'll come out in the course of this course, and we'll talk about it as it comes out. If you've ever seen a dipstick test, this is how they work. There are very common pregnancy dipstick tests, of course, and also you can go to a doctor's office and get a rapid flu diagnosis via dipstick, where you take a nasal swab and put it on the stick. These are absorbent pads. onto which you have antibodies, which are linked to colloidal gold, and these are antibodies against your virus protein. And so the physician will put a clinical sample here. The liquid will move down by capillary flow. It'll pick up the antibodies, and then it will move in this area where there are capture antibodies that will capture this. This antibody will bind to this antibody, and if it's positive, then you will get a test line showing positivity by the gold, because that'll show up as a dark line. And these have internal controls built into them. That's what the control line is, just to make sure the test is valid. So these are being increasingly developed, not just for doctors' offices, but for using in the field. You can go into field conditions where you don't have any equipment and use these, and some of them are being made to make a QR code that you can then photograph with your phone and send back to another lab, and the QR code that forms says whether it's positive or negative. It's really very cool what can be done. We use green fluorescent protein a lot in virus research. That is, of course, a protein originally found in jellyfish, which fluoresces under light. There it is. There's the jellyfish. There's the green fluorescent protein. And now we have been able to make many, many different colors by altering the amino acid sequence of the original green fluorescent protein. And here is on the right an experiment where they have used herpes viruses with 7 different colors, yellow fluorescent, red fluorescent, etc., and infected them all in a single cell. And you can see the array of colors, each a different infected cell making a different color. So you can do very interesting tracking experiments. On the left is a cell infected with HIV-1. I'm going to turn the lights off because this is really very beautiful. What we've done here is we've infected with HIV-1 that is labeled with GFP. Those are the green dots. You can now see individual virus particles by light microscopy. The light is bigger than the actual particle. So those are particles of HIV-1, and these are moving into an infected cell. And these red streamers, this is the tubulin assembly of the cell labeled with an antibody, and these viruses are actually moving along the microtubules towards the cell nucleus. So we can do all kinds of what we call single particle tracking and cell biology of virus infection using these fluorescent protein markers. It's really quite remarkable. Then, of course, we have polymerase chain reaction, PCR. And I love this story because this started in the 60s. A microbiologist by the name of Tom Brock, he was at the University of Wisconsin-Madison. He was really interested in what bacteria grew in the hot waters at like Yellowstone. And he isolated bacteria, and one of them was Thermus aquaticus. And from that, many years later, someone isolated the DNA polymerase. It's called TAC. TAC polymerase, it turned out to work at high temperatures. Of course it does, because the bacteria live at high temperatures. Completely accidental discovery. Yet this has revolutionized research and diagnostics, because PCR is used for everything. And the way it works, of course, is you want to detect the DNA, you make primers, and you do a polymerization reaction. You denature the template, you add your primers, you allow the product to be made. So now you have originally 1 DNA, now you have 2, you denature those, repeat, you have 4 now, you have 8, 16, 32. You do that over and over, and eventually you get a lot of DNA that you can detect, whereas what you started with, you might not have been able to detect. We use this in the lab, we use this in industry, we use this in diagnostic. Most of the diagnoses of the new coronaviruses have been made now by PCR because we don't have an antibody-based assay yet. And I want to finally tell you about sequencing, which is the last rung of this revolutionary ladder. When I was a postdoc, I did a kind of sequencing called Sanger sequencing, where you run samples on a gel and you can manually look at the sequence and determine it. It takes a long time. But since then, high throughput sequencing has been developed where you can sequence millions and millions of bases in a day of many, many samples at once. This has spawned the field called metagenomics, where you can take any sample anywhere and just sequence everything that's in it. We can identify new viruses. This is how the new coronavirus has been identify new pathogens. The whole human genome can now be done in a day for $1,000, and that price keeps dropping. And I wanted to tell you what we do with this and how it's been applied to the new coronavirus. First, the data that you get from this high throughput sequencing. We now have computer programs that can analyze it. And one of the things we do is make phylogenetic trees to compare different sequences, how they're related and how they've evolved. And this is a typical phylogenetic tree. Here we have 10 different viruses that we have arranged on this tree that are related. The way the tree works is from left to right is the degree of genetic change. And there's typically a scale on these phylogenetic trees, which is in the number of changes over the length of the sequence that you're looking at. Then you have numbers here, which are called the measure of support. This is an indication for how well these sequences cluster compared to any other clusterings that you try. And again, programs can do many iterations of the comparison to do this. And so, for example, virus 1 and 2 are more related than virus 3 and 4, and they have a common ancestor. On the left of the tree, this tree is rooted, which means there is a presumed ancestor there of all of these viruses. Most of the time, we don't actually have the rooted virus isolate because it's too long ago, and so it's implied. And so this will tell you that if you get a new isolate, we can do this analysis and see where it fits in. We're going to talk about this a lot in this course, so I want you to understand how it works. Now, here's one of the first papers that came out from China a few weeks ago on this new coronavirus. So this is from the China CDC Weekly, and this is the novel genome. So let's go through what they did, because I've explained to you every step of this process. So they had a sample of bronchoalveolar lavage from a patient who had pneumonia. So they put a tube into your lung all the way down to the bronchi. They put in a little PBS, and then they pull it back out again. And then they say they did a combination of Sanger, Illumina, and nanopore sequencing. Sanger is the old style sequencing. The others are high throughput. So they take this sample and they extract the nucleic acids. Now, if they're looking for an RNA virus, they first have to use PCR to convert it to DNA, because these high throughput methods only work with DNA. They got the whole genome from this sequence, 15,000 bases, and they did phylogenetic analysis. Okay, so from a wash from a patient, the entire genome, phylogenetic analysis, that's shown here. This is done by the EcoHealth Alliance. And here's the phylogenetic tree of many coronaviruses, and here is the Wuhan isolate from December. So what they've done here you can see the scale. There's no numbers here to indicate the quality, but you can always get this information from the raw data. The tree is based on partial gene sequence, 400 base pairs of the RNA polymerase. The RNA polymerase is the only protein conserved among RNA viruses, so it makes sense to just look at that. There's a huge database of virus sequences that you can access and do this with. And look, here it is. It's right next to bat coronaviruses and the SARS coronavirus from 2003. So boom, that's immediately put in there without knowing anything about the virus. The sequence immediately puts it on this tree of coronaviruses. You know exactly what it is, very closely related to a bat coronavirus. So anyway, that's how they figured out that it was this new virus. Now there are tons and tons of new sequences arising, and as things emerge, I will tell you more about it. This is done all the time, this high throughput sequencing to identify new pathogens. It didn't just happen in the corona story. Here's two stories of a virus that was causing disease in snakes and a new tick-borne virus in humans. But I want to leave you with a warning. PCR product is not the same as infectious virus. Please don't assume it's the same thing. Here's an experiment that shows that. We took mice, infected them with Zika virus, and then measured virus shedding in seminal fluids. And that's shown here. Infectious virus peaks at around day 15, and then it goes away. But if you do PCR for RNA, the RNA can be detected out to day 60. But there's no infectivity there. That's because these are just pieces of the viral RNA that are left, and these will give you a positive PCR signal. So it's very important to understand that just because you get a positive PCR doesn't mean that there's infectious virus present. Now, in an outbreak situation, we know that a lot of people are infected with this virus. You can assume a PCR positivity isn't diagnostic. But when you're doing discovery, you have to make sure you get infectious virus in the end. And that's what they have done in China. And I want to end with this story of viruses associated with illegally imported wildlife products. People like to bring in pieces of monkeys and other animals from other countries that are dried out. They get captured at JFK because they're illegal to bring in. And a laboratory ground them up and sequenced them to see what was there. And they found viral sequences, but there's no infectious virus here. It's just little bits of RNA that are left and you can amplify. Yet, the New York Times says viruses cross borders. There are no viruses in these samples. It's nucleic acid, little bits of nucleic acids. But of course, if the headline writer wrote pieces of nucleic acids in illegally imported wildlife, the editor would say, no way, you're not going to publish this. So I understand that. But I just want you to know, this is not infectious virus. This is just nucleic acid. Okay.
All right, so that's the end of this bill today, man. Like the video, share the video, tell a friend to tell a friend that we having Science with Shawn. Now, I am going to do some extra preliminary work. I will be back in approximately 5 to 10 minutes with another show. That show will be on Kofi Pie Side Research Team YouTube channel. It'll be pretty much an after show. We're going to deal with, I should do it here, but we're going to deal with a news article that people aren't really reading. And then I just need a second to get all my data lined up. And then we will be back live. Now, I don't want to bore anybody. I want to keep this nice 2.5 hour video. I think we took a lot of time because we had the little thing. I should have left that out of it and just did the actual lecture. That would have been an hour. And then the other part of it would have been, the quiz that we did earlier on. So give me about 10 minutes. Now I'm gonna come back on the mouse. Hi, ladies and gentlemen, the books is in. The books are in. Yep. They're in. They're here.